بسم الله الرحمن الرحيم، والصلاة والسلام على نبينا محمد وآله وصحبه أجمعين. في البداية أود أن أشكر الدكتور عدنان حبيب والدكتور مازن دوماني على هذه الدعوة للمشاركة في مؤتمركم Dentistry Online، وأسأل الله عز وجل أن يجعل هذا العمل خالصا لوجهه الكريم وأيضا في ميزان حسنات الأخ عدنان ومازن. موضوع الذي أود أن أتكلم عنه اليوم هو the controversy over the long-term survival of endodontically treated teeth and dental implants. مقارنة حقيقة ما بين المعالجات اللبية وزراعة الأسنان. فكثير ما يخطر في بال الأطباء هو صنع قرار معين باتجاه القلع وإعادة القلع والزرع أو المحافظة على السن ومعالجته بالطرق المحافظة. لعلي في البداية أقدم نفسي للأطباء والطبيبات الزملاء والأخوة والأخوات. أنا شهاب رميد، استشاري في زراعة الأسنان وفي معالجة أمراض اللثة، وأيضا اختصاصي في المعالجة اللبية وفي التعويضات الأسنان والتعويضات الوجهية الفكية. حاليا أشتغل في كوين ألكسندرا هوسبيتال في بورتسموث in the UK. كنت سابقا أعمل senior lecturer at King's College London. أيضا اشتغلت في مشافي عديدة في لندن وفي ال UK in general في اختصاصات مختلفة، وحاليا ما زلت أعمل في وزارة الصحة لمدة 3 سنوات كاستشاري، وأيضا أشرف على بعض طلاب الماجستير وأجري بعض الدورات التدريبية لأطباء الأسنان في مجال المعالجات اللبية، زرع الأسنان، أمراض اللثة. وأنا أيضا الدايركتور تبع لندن دنتال أكاديمي في مجال التدريب. فأي منكم أيضا يود التدريب في أي مجال من المجالات ممكن نستطيع أن نوجهه في اتجاه معين أو نقترح بعض الاقتراحات المعينة، خصوصا في التدريب في اليو كي، حيث ما زال لي أشتغل أنوري مرتبط في كينغز كوليدج لندن، وأيضا من خلال الأكاديمية التي قمت بإنشائها في العام الماضي. أيضا أعمل في سنترال لندن في عيادة خاصة على part time basis. بالنسبة للمجالات العمل في المشفى طبعا مختلفة تماما عما نقوم بمعالجته ورؤيته في العيادات الخاصة. في المشافي معظم المرضى الذين يأتون إلينا هم من مرضى السرطان في الهيد النك، وأيضا معالجات المعقدة والهايبودونشيا والتروما clefts cases, very complex cases, quite different from what we can see in primary care sector. حقيقة أنا المعالجات التي أقوم فيها قد تكون متساوية من ناحية المحافظة على الأسنان، معالجة الأسنان لبيا وترميمها، أو زراعة الأسنان، ولكن زراعة الأسنان قد تكون متقدمة جدا، خصوصا في أمراض cancer patients, head and neck patients, trauma hypodontia patients كما تلاحظون في هذه الصور. وأيضا نقوم في بعض زراعة الأسنان كzygomatic implants, maxillofacial implants for advanced reconstructions، وهو أيضا كثير وشائع ونقوم فيه بشكل دوري في المشافي. بالنسبة لموضوع المحاضرة سوف يتطرق إلى هذه المحاور. أولا نجاح المعالجات اللبية أو إعادة المعالجات اللبية، وأيضا نتطرق إلى السيرجيكال ريندودونتيك تريتمنت، نجاح زراعة الأسنان وبعض الاختلاطات المرتبطة بزراعة الأسنان، وأيضا نقوم بما هو الربط والفاصل ما بين زراعة الأسنان وبين المعالجات اللبية، وكيف نتنقل من محور إلى آخر في هذه المعالجات وكيفية صنع القرار. كما تعلمون صنع القرار هو ليس بالسهل، ولكن اعتمادا على الإيفيدنس. توربي نجاد published very comprehensive paper or systematic review talking about the success rates of dental implants, bridges, and endodontics. What he found that the success rate of implants endodontics is quite similar, about 95%, but the bridges they've got very low success rate, less than 80%. فالجسور عادة ما مرتبطة تكون بفشل كبير، ومنها الفشل الميكانيكي والفشل البيولوجي. معظم الجسور التي تأتي قد يكون فيها leak، قد يكون فيها disintegration للمارجنز، وأيضا peri-apical pathologies in most of the cases. ولكن ما يلفت الانتباه في هذه الدراسة أن قليل ما هي الدراسات التي قد أدخلت في systematic review. نلاحظ هنا فقط دراستين لزراعة الأسنان في مجال randomized control trials، هنا أيضا 4 دراسات، ولكن في الجسور قد نلاحظ دراسات متعددة وطويلة، والevidence stronger. It's been in use for many years. حقيقة صنع القرار ليس بالسهل، وكثير منكم يتساءل متى نخلع الأسنان ونعيد تعويضها في زراعة الأسنان أو بالجسور، ومتى يمكن لنا أن نحافظ. القرار ليس بالأمر السهل وليس بالطريق المستقيم، وإنما يحتاج إلى عدة مزيج من الأشياء التي يجب أن تؤخذ بعين الاعتبار، منها الخبرة السريرية، منها level of training، يعني كم هو متدرب الشخص على القيام بإجراءات معينة، أيضا الإيفيدنس المرتبط بهذه الإجراءات، وأيضا مهم أن نعلم ما هي رغبة المريض وما هو وضع المريض المادي الاجتماعي، وما يفهم المريض وكيفية فهم المريض لهذه المعالجات. في المعالجات اللبية كما تعلمون هناك نوعين أو هناك نوعان من المعالجات. النوع الأول يسمى المعالجة الأولية، والمعالجة الأخرى هي المعالجة الثانوية or secondary RCT. For primary, we're dealing with virgin teeth, like these cases. This is a cancer case, came to me long time ago, where I did root canal treatment on the lower left 5 and 6. The most important about success rate النجاح، هناك عوامل يجب أن تكون مرتبطة. فدراسة إيسمان إنجي and كوش أو كيش كولابيفالا they talked about success rate and success factors and prognostic factors. First of all, most important thing, coronal seal. Coronal seal as important as the apical seal. Second thing is the root canal treatment quality has to be condensed, free of voids, and has to be within 2 mm from the apex. And the success will increase when you don't have any peri-apical pathology. لما ما يكون في أي إنتان حوالين سن المعالجة سوف تنجح، والنجاح يكون كبير. ولكن عندما ننتقل إلى نسب النجاح فإن نجد هناك نسب تتراوح ما بين 70 to 85% in the primary root canal treatments. As you can see, this is a patient I treated a long time ago, and I would expect this to do very well, especially the upper left 7, due to the fact that root canal treatment is of good quality. There is enough coronal seal, and also most importantly there are 2 marginal ridges which are still intact. So this tooth will not need any extracorneal restoration or full cuspal coverage in the future. ما هو أهم هو absence of any preoperative peri-apical pathology or radiolucency, root canal filling within 2 mm from the apex, no voids presence, and satisfactory coronal seal. So these are the factors or criteria which we need to look at when we do our root canal treatment. Same group at Eastman in G looked at about 1200 primary root canal treatment and about 1300 secondary root canal treatment. What she found, their success rates quite close, 83% primary, 80% for reendodontic treatment, which is not that far. But the problem is, this is one of the cases I did a primary on the upper left 7 and secondary on the upper left 6, as you can see. When I did the secondary root canal treatment on the upper left 6, I had to warn the patient about the success because I had to remove the crown, assess the superstructures or assess the tooth tissues quality and quantity, and looking at the infection and access to the canals is not always predictable. But looking at the upper left 7 is quite predictable. It's easier to go to the treatment, and as you can see, Naya amalgam core did very well, extracorneal restoration crown, and both crowns actually both teeth being crowned at the same time, one with metal ceramic, the other one with full coverage metal ceramic, due to the fact the first one, upper left 6, was already crowned, so there is some sort of destruction already took place. I did not increase the destruction of the tooth or the reduction of the occlusal surface, but the upper left 6 I tried to be minimal. As you can see, the contour of the metal is quite as you can see, marginal or less than the upper left 6, as you can see, conical, and the taper is over 15 degrees, and that due to the fact that this tooth was already prepped before. When we look at the success rate, it's quite important to define our success criteria before doing the treatment. What factors would tell me that my treatment is successful? What factors saying that my treatment is actually compromised or might be compromised in the future and has got guarded prognosis? And what factors could tell me that treatment would fail at some stage? Strandberg defined the success rate as having asymptomatic tooth and has got normal periodontal architecture around the root and having fully healed in terms of the bony infill after the treatment. These are theoretical success criteria. Somebody sitting and saying these are my success criteria. You are raising the bench and the bars quite high for other people. How many times I would achieve 3 objectives? I see very, very few cases I would be able to deliver treatment which give me asymptomatic tooth, normal architecture around the tooth, and fully healed in terms of the bony infill. While as if you look at the other study, which is more realistic study, Van New Heinsen, what he said, he said that even though you have got some radiolucency around the teeth, you might get away with things without the need of redoing the treatment again. So having radiolucency around the tooth, he looked at 420 teeth over 6 years period of monitoring. And what he found, about 95% of the teeth with radiolucency kept status quo. Only less than 5% or 3% caused some problems and failed, and 2% fully healed completely. So if I take the second study, I would say success rate with reference to the first study is only 2-3%, which is not true. So I need to be careful how I define my success rate. And this radiograph on reflecting the upper left 5 and 6 patient was symptomatic, having some problems. The upper left 4 was TTP and tender, causing some symptoms, but upper left 5, although has got radiolucency, did not have any problems. So having had root canal treatment, which I did a long time ago in the upper left 4, left this patient asymptomatic, having no problems with these teeth, and I avoided destruction by removing the post-crown and doing root canal treatment. So having this radiolucency around the 5 does not mean that this tooth would necessarily have or would have root canal treatment. In fact, looking at the success, I would add to the NG and the Eastman group, they looked at the periapical radiolucency. I think from my point of view, I would say when you look at the tooth, it's how much tooth tissue is left there. Is it restorable? Don't underestimate the proximal caries, which most of the time you see very difficult to isolate, very difficult to restore once you have got subgingival caries. Sometimes, as you can see, very close to the bone level here. Am I able to get full access to all canals, like this case here, as you can see? Am I able to put a crown which will seal the margins perfectly? Because if I feel that the margins are not sealed properly, then I don't think there is any point of doing root canal treatment at the outset. So I'd remind myself and my colleagues here, and humbly I would say, please look at the superstructures, look at the remaining tooth tissues. Do you have the ability to produce a restoration which seal the tooth completely? And the living document being produced a long time ago by a Troop study, which indicated that the coronal seal is as important as the apical seal. So going back to some studies, and this very nice systematic review looked at the endodontic treatment by Friedman, Canadian endodontist, who looked at the studies almost over 50 years and other studies over 10 years and put the weighted average of success in both studies together. And what he found, that the endodontic treatments for primary or for the first time will have a success rate over 90% if we don't have any sort of radiolucency around these teeth. But when you have got radiolucency, the success will drop down by about 15%. Now, what he also suggested that multi-visit would be more effective in terms of getting better results and outcome for the patient than having single visit by about 10%, as you can see, from 79 to 70%. Now, if we fail at this stage by our reendodontic surgical endodontic treatment, then the surgical reendodontic treatment, or we call it apicectomy, again will be less successful by about 10%. So is that on a sliding scale by 10%, 10%, 10%? The likelihood of success with the first treatment, 90%, drops to 80%, and then probably down to 60% if we're doing surgery for the patients. But most important thing, looking at these treatments here, these studies, 50 years is quite a long time. 34 studies being assessed, 38 studies, long studies all put together to get these outcomes. But look at the range of the success or weighted average. The range between 38 to 96, the average is 76. It's quite varied in terms of clinical outcome. Is how much reliable, how much is solid is this evidence? We don't have actually any quality assurance in terms of data collection, data analysis, putting these results together. But the fact is that time, 50 years ago, having all these studies being put together is a great work, great job done by Friedman and his colleagues, and also by the people who carried out these studies. But nowadays, I think we are more accurate in getting all the outcomes, and we are more specific in terms of the success criteria and well aware of the success and the survival of these teeth. So I would say if you look at these figures, I would say rather than looking at the success as such, I would say looking at the survival, because these teeth you will come across a lot of problems: loss of crown, decementation, open margin, restorations, fracture, chipping. So the success is not purely based on the fact you do the treatment and you do restoration and leave the patient for 50 years. That's not going to happen. Now, if I look at this clinical case and I would ask you all, would you be able to restore this tooth, the upper right tooth? Or do you think, well, looking at this tooth, I don't think it's restorable. Is it worth all the time and efforts and putting the money from the patient side to have this restored? Or shall I just extract the place implant having bridge? It's quite important discussion. And the fundamental issue here, you need to engage with the patient. You need to engage with the evidence and your expertise. Am I able to do this? And if I do it, how likely I will get this treatment successful? How likely I will get this tooth restorable? It's quite, I think, difficult sometimes to take such a decision. And as you know, medicine, like anything in life, there is no black and white, and there is no right or wrong, but there is the best decision. And this decision, you and you only will be able to make this decision with the patient by engaging with the patient. In my views, I think the most important, before looking at the technical side of doing a root canal treatment, is the tooth restorable. And MacDonald and Sichel from the Eastman puts very nice index, they called it Tooth Restorability Index. I encourage all of you to read about it. They're measuring the length of the remaining tissues in 6/16. So the tooth being divided into 6/16, and then measuring the height of the walls in these 16ths. If you've got less than 9 in terms of the overall, each wall will be assessed from 0 to 3. 0, nothing left at all. 1 is less 1.5 millimeter thick or dentinal wall, or more than 2 times as high as their thinnest part. 2 is questionable between 1 and 3, and 3 have got adequate height and thickness. Now each one, if you get 3 walls with score 3, then you will get, I would say, decent outcome, questionable. But if you get more than 12, so 4 walls with measure 3, which means that you have got adequate height and thickness, the tooth will be restorable. Now if you've got 3 walls or even 2 walls with 3 walls with the score, I would say 3 as 9, and then also with core buildups with some posts, I might be but anything less than 9, unacceptable to retain plastic core or even IR core, and then I would say there is no point, and the only thing either to do crown lengthening or you do cast posts and core, and that's the as you know, it's quite technically difficult sometimes, especially at the posterior region, without having a proper seal. So I'll go back again to the same case, which I'd like to discuss tonight with you guys to see what you think. This gentleman, healthy, no active caries, periodontal disease. He had a trauma, young patient, healthy, and he's fit and well. Thick gingival biotype, nice mucogingival junction, there's some racial pigmentation. This patient will heal, in my hands, doing implants, will heal very nicely due to the fact that it's very healthy mouth, no active disease, thick gingival biotype. was seen by his dentist, did root canal treatment on the upper central and crown, but came to me for the upper right too. What should I do? Shall I extract the place implant immediately, and which could be done predictably, or shall I attempt doing the treatment? In fact, we need always to think about the best strategy and make the best decision for the right patient at the right time. We need always to think, well, having all these factors in mind, am I able to deliver something predictable after long treatment, or am I going to cause more difficulty for the patient? It's quite important discussion. Looking at the occlusal surface, I think the palatal wall is not too bad at all. I've got 2-3 millimeters. The mesial, distal, not too bad. The buccal is completely, there is chisel type fracture, but still at the gingival level. Look at my plan. I think you might agree or disagree. That's you are entitled to your opinion. But looking at the root canal treatment, technically is not complex, straight single canal. The MAP on the apex, there is slight radiolucency, not too bad. But decision was made at that time, that a long time ago actually, to have a root canal treatment, leaving the post or the space of the we call it the backfilling empty, and thus I prepared it at the same time while I was doing the downpacking to have a fiber post. And the post I decided on, as you can see, is here completely cemented, very nice adaptation, and I built the whole tooth with composite along with the post in order to get the patient out on the same day having a tooth restored and also root canal treated along with the fiber post. But the point is, I would like to make here, what sort of post do I need to do here? Direct or indirect, metal or fiber? And if it's metal, what sort of metal post? Is it tapered? Is it parallel sided, or is it serrated, or is it screw type? I opted to go for something called Everstick post, as probably some of you would know. This post is a Finnish company used to produce very nice posts. It's moldable, and it can be shaped to get the shape of the canal, which we call it anatomical type of post. Get the posts or the fibers together, get them inside the canal. I can adjust them, I can cut them, but always to make sure that they have got enough adaptation and perfect fit of the post inside the canal. And then we start with slight curing, probably 2-3 seconds to get it the shape I want, in and out. And then once it's ready, I will cement it using, I would say I would not use 4th or 5th generation. I would 6th generation would be perfect, because etching is inside the canal is quite difficult. I can't predict that I will get the right substrate, let alone the fact that I might end up with destroying the collagen network inside the dentinal walls. Therefore, 6th generation, which is self-etching polymer, is quite suitable for these cases. You will have the both, we call it the primer and bond mixed together. Self-etching, monomer would be very, very useful. And this is similar to Panavia type cement. I use a lot of Curare products, quite nice products in this respect, give me predictable bonding. But most important thing, you have to bear in mind, if you do use the 4th or 5th generation, you need to make sure that you don't have pulling down effect, because if you get the primer or the bond completely pulled inside, you will not be able to put or to place the post at the same dimension you already measured, you already obtained by the preparation and adaptation of the post. And then after building up the crown, I reduce it down, and then I will start making the definitive crown, which could be an all ceramic crown, as you can see in this case. So building the whole crown first, taking putty index, and then prepare it and make a definitive crown. Make sure always out of anterior guidance, and even with canine guidance, there is no contact of this crown to avoid any shear stresses, chipping or fracturing of this crown, or dismantling the whole structure. Sometimes, most of the cases coming, especially with deep overbite, you will see the patient holding his hand in his hand, the crown with the post coming as one piece, and that's by mechanical failure. It's due to the fact the bonding was not great, or the dentist did not pay attention to the dimension of the post. Another case here for a mid-40 school teacher had sustained trauma on the upper anterior or mid-face, resulted in a fracture as you can see, the upper left one, severe fracture, including the enamel dentine and part of the root palatally. I would say here, both of these fractures are complicated fractures, involve the pulp, who ended up with having two root canal treatments. And then looking occlusally on these teeth, you will find just little loose tissues left on the upper right one, and then the decision is whether we are able to restore this tooth or are we planning to extract, placing implants. Again, sometimes decision, we run out of time, we run out of options, difficult decisions sometimes had to be made, and also sometimes when you make a decision you need to look at the consequences. Having implant for this patient, what are you going to do in the interim? Are you going to extract, putting partial denture, putting a resonant bridge? There are many complications, and we need to take into account these adjacent teeth. One of them is rotated, the other one has got small surface, bonding might not be predictable. Therefore, having a direct types of buildups on these teeth with fiber posts and direct composite buildups. In this case, we use prefabricated paraposts from Wheeler-Dent. Quite a nice thing to do. Not necessarily always follow this, I would say, because of the destruction you might impose. And we need to be very careful for those who are new to this type of treatments, not to cause any perforation, any undermining the root structures. As I mentioned, the first type of post from Everstick or Stick Tech, much better in terms of the conservation. And when I finish my root canal treatment, straight away I can place them, bond them, and build the teeth. So these both being built. I'd had to do some crown lengthening around these teeth to isolate the margins and then do direct composite buildups. In the first instance, I did 2 composite buildups to full contour of these teeth. Isolation and composite and bonding strategy is quite important. Unlike the first one, bonding case, bonding post, normally we use 6th generation primer and bond, no etching. But building the whole tooth, we need to etch and rinse, which is the 4th generation. We need to have a primer and bond. I try to avoid 5th and 7th generation. So 4th generation is the gold standard. Primer, bond, and etching and rinse technique is more predictable. Try to get all your setups, all the gears at the chair side. Make sure you have got the nurse and the setup ready for such procedures to have predictable treatment outcome for the patient. Quite technique sensitive. You can finish that in one session, and the treatment walk out happily from your practice or your hospital. So make sure that the patient followed up. If you want to do any indirect restoration in the future, that's something it's possible. Again, you need to avoid any sort of contacts in the anterior guidance. Make sure that the lateral guidance, all canine groove function, avoiding any contacts in the centrals, and also warn the patient any shear forces, stresses might strain these restorations and might cause some sort of cohesive or adhesive fracture. So the point which I want to make, what sort of posts, what sort of materials, does not mean to me a lot. The only thing I would say, avoiding these posts as much as you can, because they create a wedging, or they call it wedging in effect within the canal. They stress the canal. They cause, most of the time, we call it vertical root fracture. They cause a lot of cracks and invisible cracks, but they are also associated with lesion. And you will see people coming with sinuses in the mid of the root, and that would give you a sign that these roots are being cracked or stressed. Fiber posts quite gentle, bonding is key, and I think using them in the anterior quite nice. Preparing them is not difficult. I would prepare them the same root canal treatment session. Metal gold posts are the gold standard still. Gold is the gold and gold standard, and we have to keep our eye all the time that cast post is quite difficult, but it's the gold standard, I'm afraid. Quite expensive, challenging, technically challenging, but I think in terms of technicality, in terms of the longevity, is the best in the market. Regardless of the material, regardless of the design, tapered gold I think is quite good. It's quite predictable for the anterior fiber post, works well. But as I mentioned, it depends on the tooth, how much tooth tissues, but most importantly, the ferrule effect, if it's not present, there is no point at all to go doing any post. So no ferrule, no post. There is ferrule effect, at least 2 millimeters left. Then post might help to stabilize the core materials. Figueroa in 2015 presented a very nice study about the posts, and he compared fibers with metal posts. What he found, the catastrophic failure could only happen less than % both fiber and metal. But the problem is when you look at the metal post, you will see here in this case, this post was used inappropriately in the distal root of the left 6. Therefore, these results not necessarily reflect these clinical scenario because these are randomized control or high-level studies in terms of randomization control on terms of case selection. But this is a poor case selection, ended up with catastrophic failure, and hope that these results will not reflect. So looking at the results of this, comparing the root fracture in both posts is about 6 to 7% with no significant difference between these posts. Incidence of post fracture is quite high when you use fiber posts, almost 18-19%, lower in metal posts, about 10 to 12%. So I think fiber posts do less or well than the metal post, and also the fracture, if it happens, it will be a problem for fiber posts because it's quite difficult from our point of view, removing the post, retrieving and replacing the post or restoring the tooth. Generally speaking, what's the survival rate of metal versus a fiber post? Both of them doing well, over 80%. As I mentioned, gold post is really the gold standard, doing very well, about 86-87%. Fiber post about 82%. But don't ask for troubles. If you're going for anteriors, it's quite important to maintain the seal while doing this post, the type of post. You need to have temporary crown. Are you prepared? Do you have the level of training and the experience to do it? Many questions we have to raise and we have to address prior to embarking on such complex procedures. And also the impression technique is quite important, the fit, and quite important. By the way, retrievability of this post is quite simple, could be done by ultrasonics if we need to do root canal treatment in the future. Now, when do we need to do surgical reendodontic treatment? When exhaust all the conventional methods, we done the primary, secondary treatment, still we have got presence of symptoms or periapical lesion. Rather than having the tooth out, still we have got a chance when we're doing apicectomy reendodontic treatment. I've noticed some people doing surgical reendodontics straight away. These could be limited to a certain extent when you've got posts, when you've got difficulty where the patient can't cope with treatment, or even difficulty getting access through the canal. Then we will go. There are some criteria being set out by the Royal College of Surgeons, about 5-6 scenarios where we can't do endodontic or reendodontic treatment: presence of post, presence of screws, difficult access, some ledges, fractured instruments, and also the patient's factors could be the patient can't cope with the treatment, difficult to put rubber dam on, so on and so forth. Sitzer did very nice systematic review comparing apicectomies using magnification, non-magnified surgeries, and using microsurgery, non-microsurgeries, and looking at the use of bioactive, non-bioactive materials. Of course, always advocated to use bioactive material, but the most important thing, rather than having only bioactive, which is, there are some studies indicating that they are osteoconductive like MTA, and biodentin with silica type materials. But the most important thing about this is the technique itself has to be atraumatic, has to be microsurgical, using the microscope or magnification is quite important, and the success rate quite evident in this slide. As you can see, Sitzer did 2 meta-analyses. He's a retired endodontist, Philadelphia, well-renowned endodontist, and he did very nice studies, as you can see, using the ultrasonic tips. It's quite helpful in terms of getting retrograde filling with nice, decent seal, where he found that the magnification increased the success by 10%. The conventional versus the microscopic, almost there is about 10% difference in success rate. And having conventional versus microsurgery, always there is about 30 to 40%. So using microsurgical kit under microscopic environment, it's quite important to get high success rate to reach that level. Now, if you don't have all of that, I think my advice is not to get yourself embarked, because the success will be poor and it's just be waste of time and waste of resource. How about the situation where we can't save the tooth? Well, single implants still valid options, crowns. Of course, there are some types of treatment which are called complex, but I would suggest that those people doing implant, they should be trained, able to deliver quality treatment, predictable and long-term outcome for the patients. Not everybody coming like this hypodontia cases. You get more complex cases, which I will touch on in this, like this case, for example, single implant, but the patient has got heavy bridge, long span with cantilever upright, to refer to me for mucogingival surgery because there was a gap between the pontic and the alveolar ridge. By that time, I decided to section the pontic, and looking at the gingival biotype is quite healthy, but there was a concavity. When I placed my implant, there was a concavity and there was some dehiscence, as you can see, or fenestration of the buccal plate. Again, with GPR techniques, quite predictable, and having some collagen membrane and apically positioned flap. This has to be tension free. That will give you nice implant placed, and I'm sure this patient has been restored successfully. But you need to be careful about the, as you can see, deep eye, the anterior guidance, all these occlusal factors has to be considered at the same time. This is to the contrary of the first one, and conversely, this one is quite complex. A patient with cancer, floor of the mouth, resected the floor of the mouth and the mandible, and which was reconstructed with 2 DCIA flaps taken from the hip, which are vascularized flaps, as you can see in the X-ray. 2 vascularized flap, we call them composite flaps, soft tissue and bone taken from either side of the hips and put together with the plate, the 8 left as is. And then quite difficult to do a conventional, so I decided to do like a guided surgery. And when I did the guided surgery, it was difficult for me as well to get the right position because the presence of the plate and the screws. It's quite a complex case, I have to say. This is a type of hospital case. But again, when I decided to do the guided surgery, the implants, as you can see, were not in the right position where I wanted to be. Therefore, I had to open big flap and place my implants with a direct procedure. The point is, putting 6 implants, poor bone quality, long-term prognosis. Always you have to calculate to work out things properly. If you don't work out all the factors, you might miss something. And then if this implant or a couple of implants placed, I still have got enough implant to provide patient who's 66-year-old with good quality of life. Now, looking at the success criteria, we looked at the success criteria for endodontic treatment. What about the success criteria for implants? Albertson, 1986, put a set of criteria, which I think is very, very difficult to follow these days, because we have got different surgical techniques, different biomechanics, different configuration, and different criteria. Having implants saying success rate over 85% is quite low. Now we have got over 95%. Having bone loss every year is not good news for us, and also lack of mobility, radiolucency. For of course, this is a no factors for our implants. But having this lady, for example, who have been treating for many years, would you consider these implants completely failed or completely survived? I would think these implants survived, did very well, because if I lose this implant, the patient will end up, she's over 80-year-old, will end up to be edentulous. So these 3 implants, she used to have 6 implants, now ended up with 3 with a bar on the top, and having these all supporting my overdenture, that would help the patient give a good quality of life. So you need always to consider, according to these criteria, these implants are failing or already failed implants. But there are some studies talking about failing and ailing implants. If you consider the ailing implants, I think these ones doing really, really well, and I would expect them to stay for a long time. I just get my hygienist to maintain the threads all the time, to give the patient some instructions how to keep the threads clean if possible, along with some maintenance from my point of view. So basically, and looking at the bone level from time to time. So dental implants not free of complication like endodontics. Could a fracture, screws could loosen, the prosthetic, the bridge screws, the abutment screws. The tissues around it could affect it. Peri-implant disease could be peri-implant mucositis, which is not a big deal, but peri-implantitis could be difficult to treat. I think the most important factor which I want to bring to your attention tonight is that malpositioning of the implant is the factor which drives all the problems, biological and mechanical. If you don't place your implant in the proper position, you will end up with all the above complications. Therefore, if you place it buccally, you will have fenestration, you'll get dehiscence, you'll get soft tissue problems, you will get some resorption, and most importantly, the metal shine through effect will be a big problem for the patient, especially in the aesthetic region, high lip line. If you put it palatally that far, then the biomechanical, the ridge lapping, and the cantilevering process will lead to the screw fracture or screw loosening, or the abutment fracture or the abutment loosening. Now, there are some cases where we have got, like this case, complex case. A patient had, I think, 8 implants, 4 implants failed. I tried to remove one of the implants here. But again, there are some decisions have to be made. How much retention? I think, to be honest, looking at this ridge, I'll be able to make denture for this patient probably safely secure without any problem with this abutment or this locator. Would be doing really, really well without having these complex treatment, because when I looked at these implants at the body, see how much mobility is there. This is worrying. The patient is heavy smoker, not looking after. So the decision to take these out, it was a straightforward decision, but looking at the implants in contact proximity, the bone will not survive there. Maintenance quite difficult, and putting the patient at further risk of losing more implant, as it happened in this case. So implant failure is not very uncommon. It's associated with some risk factors, mainly poor oral hygiene, peri-implantitis. Smoking, alcohol, and diabetes is very, I think, a predisposing factor for more problems and more peri-implant disease. Radiotherapy is bisphosphonate as well. We need to avoid, or to send people to consultants or specialists in the field who can deal with these safely. Now, looking at the success of single implant crown, and this is one of my cases done a long time ago. I would say this one I started a lot of soft tissue loss, bone level loss, big radiolucency, first and second radio, root canal treatment failed, which was done to high standards, patient still asymptomatic, and also a lot of bone loss around the radiolucency, and on the top of that there was a fistula persistent in the area, this region. Extracting the tooth, placing implant, and putting soft provisional crown developed very nice thick gingival biotype around the implant by the GPR, as you can see here. Look at the level of the gingival margin. The emergence of the crown is amazing, as you can see here. Even difficult for me to recognize which one is the implant, which one is the crown, due to the fact the stippling of the soft tissue, the color, the texture, the closure of the and the papilla fill of this space. This is a predictable treatment, and that's why I expect all of you guys, when you embark on dental implants or doing such procedures, to have all these factors in place: the positioning, the placement, the soft tissue, the healing time, and what sort. I think there is no space now to mention all, to go into these technical things, but most importantly, I would expect this to do very well. 95% in 10 years time is not too bad, or 97%. The crown might have some problems, but whether it's metal, ceramic, or ceramic, it doesn't matter. More complex, having these cases near the sinus or inside the sinus, I think it's quite important to recognize that success still within 95% brackets, and I expect these bridges to do very well and maintained very well by the patient and by us. But having screw retain type bridges, abutment level is quite important. Raising the standards, having high level of maintenance, and also making sure these are maintained properly, quite important. The screw loosening could happen here in these cases, but 7% comparing to single implant by 13-15%. Peri-implantitis about the same level, about 10%, but again, it depends. Let me check just in case I lost a recording. It's still recording. Let's go back again. So I talked about the multiple implants. Now, when we have got full arch implants like this lady, where we have got full arch implant bridge on 4 implants, not because I like 4 implants. The fact that she's elderly lady, you don't need 6 implants. You don't need to lengthen the arch. Shorten the little arch 5 to 5 will do greatly well. I mean, this is Peterson's study again reflected in this about the implant bridge will do extremely well like single implant crown, about 95%. In 10 years, 5 years time, 87% in 10 years time, and the bridges similarly will do extremely well as well. Conventional bridges will do not too bad, 94%. The cantilever bridge will do less than that, 90%, but the implant bridge do as much, will be as much effective as the full arch bridge, and also the outcome, as you can see, is not completely, I would say, different. Is not greatly affected by the fact having single implant, 2 implants, or having full arch implants. So the outcome is quite encouraging. There is as good as clinical outcomes in both sides, whether upper or lower, whether it's a single or multiple, and the complications are still within the same range for single implants. Now, the disease which I wanted, and always you need to think about before placing implant in people who have uncontrolled diabetes, poor oral hygiene, most importantly, periodontal disease, active periodontal disease, whether it's aggressive or chronic. Those aggressive, I need to stop doing any procedure, any treatment, unless the disease is completely controlled. If you don't bring it to the attention of the patient and going there for the treatment, you're digging for trouble, you're asking for big trouble. Therefore, having all the, I can't afford losing a lot of bone. I can't afford. This is, by the way, a radiotherapy patient being placed by 5 implants. The dentist who placed the implant was lucky not to get osteonecrosis by having the surgery, unknowingly that this patient had radiotherapy. So the risk of peri-implantitis with patient with chronic periodontitis is almost 5 to 6 times higher than those who have got healthy mouths, no periodontal or disease free. And this is Zitzman's studies, quite high level, 2008. So having that all in mind, I would say peri-implantitis is inflammatory process affecting hard and soft tissues around dental implants, changing the architecture around the implant, creating craters not cleansable, not maintainable, and also it becomes quite progressive in terms of the bone loss in the future. So we need to be careful how to approach these people. So what are the risk factors for peri-implantitis, guys, when you look at the diabetes, poor oral hygiene? Don't look at the history of periodontitis as lightly. It's an important factor, as I mentioned. I would say a couple of years for aggressive, 1 year at least for chronic to make sure it's being controlled. Some type of diseases could be familial, has got familial or genetic links. Alcohol consumption by Hayes Mayfield, I think, Mayfield had strong evidence in his randomized control trial along with the smoking. Absence of keratinized mucosa, yes, it's predisposing factor, especially with lower implant over dentures, but it's not a great factor. We can always augment the soft tissues with free gingival graft. It's not a big deal. Let me discuss this case or share it with you. A patient of mine seen about 7-8 years ago, he had this implant part of full arch bridge, which has got, as you can see, creamy sort of mushroom type soup coming out of this implant. It's not soup, actually, it's a pus. And the patient was not concerned about it. But when I looked at this one, remove the bridge, I was really alarmed, and I thought, well, should I go ahead? Shall I remove the implant? What shall I do? So I went ahead with making implant bridge, but went to do at the same time is raising and doing some sort of surgical management of this disease. The good news, after 5 years, and the patient, bless him, is a very nice guy who looking after his mouth. He says, you can see the gums quite healthy now. There is a bit of bleeding, less than 5 millimeter, but this is maintainable. But look how much tooth tissues. This is called apically positioned flap. So I intentionally intended to do some sort of, to create some recession and to apically position the soft tissue around to make it more maintainable. But the implant's clean, the abutment's clean, the bridge is clean, the mouth is clean, and also this is some exposure. Would you consider this as active disease? I would disagree with you if you say that. Yes, most of the case we got some, but this is, again, this is a maxilla with full arch. The patient who had bone graft before, I think he had hip bone grafting for hypodontia, and his family as well, his children as well, he has got similar conditions, or they have got full arches for hypodontia reason. Therefore, maintaining these implants is a factor. The main message today: don't give up, don't get alarmed. You can maintain things, you can keep an eye on things, like what we do with root canal treatment. Don't extract, don't initiate re-root canal treatment unless there is a real and genuine reason for it. So with peri-implantitis, there are a few classifications available. One of the simplest ones, Stuart and Forum 2012, developed a 3-grade classification: early, moderate, advanced. They said you have got less than 25%, you will get early disease, 25 to 50%. Moderate disease, over 50% is severe or advanced. Of course, the pocketing has to be more than 6 millimeter to be advanced, less than 6 millimeter to 4 millimeter to be moderate, and less than 4 millimeter to be early disease. It's quite important for communication. Smoking, as you can see, some countries is more endemic, is more epidemic, and people smoking heavily need to be careful about how to select a patient to raise your success criteria. The risk imposed by smoking about more than 20% to comparing to non-smokers is 7 times 7 times greater complication in smokers, and smoking with periodontal disease is a lethal combination. As you can see, success is less than 80%. If I knew that my success rate would be less than 80%, I would not get myself embarked into any complex treatment, including dental implants. Surely less than 80% is not acceptable in the clinical terms to put the patient through such complex, expensive, and lengthy treatment. So 20% greater risk with smoking, whether it's root canal with dental implants. But the fact is, does that mean that this patient is suitable for having root canal treatment? Well, the answer really, I don't know, and I would say very confident that comparing root canal treatment to dental implants is comparing pear to apple. When you compare things, you have to compare like for a like. And dental implants totally different, because single implant crowns, for example, and root canal treatment cannot be based exclusively on treatment outcomes. They have got totally different outcomes. One to replace tooth, one to restore a tooth and to save it. The other ones is the mode of failure is quite different, because they are based on different biological and diagnostic principles. One based on replacing, placing a new screw, and the other one is maintaining the tooth and healing the tooth tissues or the tissues around the periapical region around the roots. So the failure mode could happen in the implants in terms of fracture, screw loosening, abutment loosening, peri-implant disease, but with endodontic or endodontically treated, it could be decementation, could be open margins, could be secondary caries, could be periapical lesion of presence of sinus, and ultimately the failure of either of them. So we are comparing alike, not for alike, and this is, I would say, my message today. If you are an endodontist, does not mean that you are able to save every tooth. If you are a good implant surgeon, you are not able to do both. But I think having both strategies together, works side by side, that would help the patient, because there are some non-restorable teeth and there is no point of doing root canal treatment. And there are some difficult scenarios where doing dental implants not necessarily will replace the tooth with the best treatment outcome. I will share with you just a quick case. This is the first case I showed you. Root canal treatment, upper left one, re-root canal treatment, MT8, and again failed at the soft tissue. This has to be extracted. You can see the amount of destruction. Placing dental implant with GPR, and again having 3 weeks later, we found the soft tissue healed nicely. Essex type retainer just to minimize the pressure on the soft tissue while the implant is healing. But later on, fixture level impression. I am sure all of you do that. Don't do close tray technique with nice embry gum solid. I'm happy to go with my provisional crown. Look at the blanching around the soft tissues, and the soft tissues start developing over time. 6 months time, you get very nice emergence profile. Another impression for the soft tissues, and finally I get the definitive crown fitted or torqued. This is another case for 2 implants. As you can see, lost through trauma upper central incisors. The options was to go for 2 single individual implant crowns, placement, minimally invasive flap impressions, the embry gum, special trays, open tray technique, 2 provisional crowns. As you can see, we need to develop soft tissues, and again leaving it for a while would give me nice treatment outcome for this gentleman, as you can see. And this is the post-op, very nice implant level around these implants, and I'm sure they're doing very well. They've got platform switching, very nice engagement, conical, and the torques these screws quite torqued, and I think they will do extremely well in the long term. And also the occlusion was designed carefully for this patient. 1 year later, the patient is happy. It's quite important to understand our treatment. Therefore, I think in essence we need to have some passion towards our career. It's quite difficult, quite tough, and we have got difficult decisions to make every day. But what will make us better clinicians is by having very, I would say, patience in terms of pursuing our career and our difficult day-to-day clinical practice. And as Steve Jobs here said in his what separates successful entrepreneurs from non-successful entrepreneurs is perseverance and grit. And I think most important, we need to train ourselves for sabr and musabara, as Allah subhanahu wa ta'ala says, Ya ayyuha alladhina amanu asbiru wa sabiru wa rabitu wattaqullaha la'allakum tuflihun. Perseverance is quite important for every single work we do. Finally, I would say thank you very much for your listening and watching, and thanks for the organizing committee, Dr. Adnan Habib, Dr. Mazen Dumani, ونلتقي في some more occasions إن شاء الله face to face, and all the best wishes. If you have any questions or any queries, please forward them to Dr. Manzin. I'm more than happy to get back to you with the earliest opportunity. وجزاكم الله خير.